I talked before a bit about where we got to, focusing really on stage A CLL, somebody who's got asymptomatic disease. I'm going to move on a bit more to talk about prognosis and treatment and choices around treatment. As I said before, in the interests of time and not losing everybody completely, I can't talk about every treatment. John was very keen that I shall not show lots of scientific data, so I shall not show lots of scientific data. Anybody that wants to look at scientific data, very happy to. So coming back to a conversation I've just had with Ian about who's a statistician, where I'm going to be embarrassed by my statistical naivety, but we'll give it a go. Anyway, prognosis. So context is critical, as I've said to you before, and so most people with CLL are diagnosed with stage A disease. And given the demographics of the average age of diagnosis in the mid-70s, about a third of people will never need any treatment during their lifetime. And so this is just in the fact, and this is, you're functionally cured. Now, okay, no one's going to live forever, but no one knows how long they're going to live for. But if you're diagnosed with early stage disease in your mid-70s, you're probably not going to need any treatment for it. 50% of people with stage A CLL die of something else, but it is still a cause of death. So we can't just, as much as anything else, it is a disease that needs treatment. And historically, this is the case, common cause of death. But I will come back to some more positive notes on that. And if you don't do any of the tests I've talked about, the genetic testing, what does it mean? Well, this was just some data from ages ago that looked at prognosis by stage. So this is in the era of not very effective chemotherapy. And again, it makes a difference if you're 75 versus 45, but if you've got early stage CLL, most people with stage A CLL have an age-matched normal life expectancy. So important to sort of not lose sight of that, particularly in that early days of, oh my God, I've been diagnosed with cancer, next thing am I, and then when that's going to be. This looks, though, in terms of prognosis by era, and this is important, and I think hopefully is heartening in terms of where we've got to. So what this is showing is loss of life expectancy, accepting that's a very gloomy concept to be talking about in terms of what prognosis is. But if it shows here, let's just look at the left one for men, and the number of years that your life is shortened by virtue of diagnosis, also by your age. So the older you are, of course, you proportionally lose left years because your life expectancy is shorter by chronology rather than CLL. But what this demonstrates, we take it, so let's take a sort of, this is the extreme, somebody who's 50. In 1989, they might have expected to lose 20 years of lifespan. So, but if you then run it forward to 2018, it was 10 years. So it's not perfect, but it is improving. And the important thing here is also, this is a snapshot, it's a point in time. All these things about prognosis, when I talked to somebody 20 years ago about prognosis, might have said your life expectancy is 10 years. But that's based on treatment that was given 10 or 20 years prior to that. And where we sit now is that actually treatment is continuing to evolve. So it's really, really difficult for me to say anything. And I wouldn't if you read books or read literature, remember this is from an era of treatment that's gone and makes no account of, it's as if treatment stands still and never changes. So this does show the fact that things are moving on. For somebody who's 80 years at diagnosis, their loss of life expectancy might only be a couple of years. Now, I'm just not saying that's unimportant, but it is putting the absolute in terms of things. And of course, we're all going to die of something, and we don't know what we're destined to die from, but it illustrates the progress. But also, until that loss of life expectancy is nothing, we've still got something to try and resolve here. Early versus deferred treatment. So the usual chronology of having CLL. I go to see the doctor, I get told I've got mild cancer, don't worry about it, go and see the haematologist, who then comes up and says, I'm going to talk about all this treatment, and then the punchline, of course, is you're not going to have any. I've got cancer, you've got effective treatment, I'm not having any. That makes no sense intuitively. And in fact, it doesn't. But why do we not rush in to do anything with somebody who's got early stage disease? Well, the simple answer is it doesn't improve outcomes. If you treat early, I can't unfortunately give you and stand up a curative treatment for CLL. Whilst I said to you that actually many people are functionally cured because they never come back in their lifetime, there isn't a treatment that you can give that will just keep it away for however long you monitor it for. And so there have been a number of studies done that have looked at whether or not you start treatment at the point of diagnosis, nip it in the bud, or you wait until it needs treating. And so going back, so there was some data, this is from the state of the art of the 1970s and 80s, which is using mostly chlorambucil, which we don't really use very much of at all, old chemotherapy, and that showed that the overall survival at 10 years for immediate versus deferred treatment was pretty much the same, about 40–50%. Skip forward to the 2000s, and this was when we were in the era of using immunochemotherapy, fludarabine, cyclophosphamide, and rituximab. So this was an attempt to give intensive treatment to people with high-risk disease. So this is some of these things I've talked about, IGHV unmutated, P53 deleted, 17p loss, and that showed that if you looked at those people that had early treatment, they had a longer time before they needed more treatment, but overall survival, that's again, I think it was 5 years, was the same. About 80% of people alive at 5 years, whether you intervened early or you intervened late. And there's another study that's ongoing at the moment. This is using modern treatment. This is venetoclax and obinutuzumab, again for high-risk stage A patients. I don't know the answer to that because that's a study that's still ongoing. And it's a live question, but as it stands at the moment, there is no benefit for early treatment. The other reasons for not giving treatment early, firstly, most people with stage A CLL are well. Whatever treatment I or anyone else gives you, I might make you unwell, so therefore no net benefit. The third reason is that treatment is evolving and improving, so there is a bit about keep your powder dry, you know, who knows, I can't tell you what I'd treat you with in 6 months, but in 5 years, I don't know, and it will be better, and it will have changed. And then the last thing is that if you have treatments, a bit like the antibiotic thing, you give some treatment now, what comes back is more resistant. So therefore you could actually make your disease more resistant by using up a line of treatment when you didn't need it. So early treatment, no benefits. But that leaves it then with the massive psychotrauma of watch and wait, or you can rebrand it as managed observation or whatever, but ultimately living with cancer, which is a challenge for many people. Not for me, I don't have it. I can't speak for you, but I know it from speaking to people every week in my clinic. It's not easy. The other bit, though, to say, and this is the other reasons not to treat, is that there is a sweet spot here in terms of when to treat. So early intervention, there's no benefit. Leaving it too late is also no benefit. And I do have several people I've seen in my clinic whereby eventually they get treated when they've clearly needed treatment and then come back and go, oh my God, I wish I'd done this 3 years ago, because all the things that I didn't even think were bothering me that I'd attributed to getting older have now gone away, and my quality of life is now miles better. So I think, it's a conversation to have, but there is an optimal time for starting treatment. So don't get it in your head of thinking, I must avoid treatment at all costs. Don't need it if you don't need it, but equally, if there's a decision that treatment might be recommended, then there is an optimum time for doing it. Eventually, you miss the boat, but that takes a long time. So it's not like it's going to massively impact, but if you leave it too late, particularly with big lymph nodes, bulky disease, it becomes more difficult to treat. So you start to actually, there's a detriment to how effective the treatment is. So it's getting it right. One thing that hasn't changed in CLL, despite advances in treatment and advances in genetics, is when to treat. And this is something that's in the guidance, and it's the same as it's been forever. So in terms of when to treat, it's not the absolute. I've had conversations with colleagues and say, what's your highest white count in a CLL patient who hasn't got any symptoms? It's not a competition, but I've got patients where they've had white counts of 400,000, 500,000, or 400 or 500, depending on which units you use, without any symptoms. And so you don't have to treat. There is no absolute point to treat. I remember seeing somebody, where I first started, came to see me, CLL, diagnosed a few years ago, his platelet count was dropping, the threshold for treatment was 100, his was 92, said, yeah, I reckon we can live on this, sit on this for a bit. He said, I've been told I need treatment because my platelet count's 92. 15 years later, he got some treatment, because it's like, so there isn't, we need to treat whole individuals, not numbers. It's like, these are all guidance, but it's rate of progression. So is the disease growing quickly? So the lymphocytes, these white blood cells, are they doubling in less than 6 months above a threshold of 30? And it doesn't matter whether they're 50 or 200, it's the rate to which they're going up. As I've said to you before, the white cells go up, the normal cells go down. So eventually you get to the point where you become anemic, not enough red blood cells, which makes you tired, low platelets, potential risk of bleeding and bruising. Arbitrarily, hemoglobin, once it gets down below 100-ish, 110, might think about it. Platelets less than 100, but as I said, not just because it's 99, therefore I treat. And then you can tell the same things. The fact of having lymph nodes isn't a reason to treat, but it's, are they big, and by that greater than 5 to 10 centimetres? Are they symptomatic? And don't be afraid to say it's symptomatic. You know, people don't like having lymph nodes sticking out of their neck and having people staring at them. That, to me, that's not vanity. That is a perfectly legitimate reason. If it's affecting your quality of life, and say, all right, it's a big node, it's not making me unwell, but nonetheless, I really, really don't like it, that's a conversation to be had about treatment. And then also other things, whether they're progressing and getting bigger, or the spleen's getting bigger. As the disease progresses, it's more likely to get symptoms. Lymphocytes produce chemicals called cytokines. Cytokines are part of your immune response to things like infection. You get flu, lymphocytes go up, cytokines go up, they make you have sweats, fevers, and weight loss. Abnormal lymphocytes doing the same thing. So sweats, fevers, weight loss, profound fatigue can be all manifestations, but they're typically, with the exception of fatigue, which I'll come back to, manifestations of more advanced disease. It's relatively unusual to have a lymphocyte count of 10, that's 1 centimetre lymph node, and then to say that you're going to get drenching night sweats. It's typically they're associated with more disease progression. Autoimmune cytopenias, that is where the immune system is upset and it causes destruction of red blood cells or platelets, and that's something that can occur in CLL, autoimmune hemolytic anemia, that can also be an indication for treatment. Now these are pretty fixed, but that bit around symptoms, that's a conversation to be had. If your expectation is fine, I'm going to get up, I go there, I'm going to sit down and watch telly and I'm going to go to bed, maybe I don't want any treatment, I'll live with it. If your expectation is, I'm a managing director of a company, I want to be working 12 hours a day and I want to run marathons, well, maybe you want to have some treatment a bit before that. So it's that individualisation. I'm coming back to the end of it. That's that conversation about when to treat. Fatigue, as I've said, and this is coming back, I was talking to Hilary about this before, I'm only going to talk a little bit about this, but fatigue, you'll tell me but it's something that I think pretty much everybody I speak to as CLL notices more fatigue. It's so difficult to unpick what's related to disease and what's related to life, getting older, grandchildren, whatever, but it is definitely a thing. And you see here, this was a study that was published this year from colleagues around the country, coordinated in Sussex, around, you can see here, treatment-related symptoms, including in treatment-naive, so untreated or in treated patients. You see here that majority experience fatigue, which in a proportion was quite significant. What can you do about it? I wish I had the magic clue to this. Some people, I have been talked into treating people against my will with fatigue and relatively early stage disease. I can think of one guy who said it was transformational, made my life better, great, I did well. Another lady I treated, and I'm sure I stuffed her up by doing it because I made her worse. And generally speaking, I have to be persuaded very, very hard to be doing it, early stage disease plus fatigue, not because I don't want it to be better, but because of the fact that the impact of treatment can make us equally likely to make it worse rather than better. But there does appear to be an association with exercise. So in this same study. This was looking at, so what this is showing you is statistically the difference between a fatigue score, so this was just asking people on a scoring thing about how fatigued they were, and then modelling against whether they believed they did not enough exercise, in red, moderate amounts, or lots of exercise. And then applying a statistical score. I'm not going to embarrass myself by talking about statistics, but p-values, this is a way of attributing statistical significance. So low p-values, less than 0.05, if the test is done right, and then that can be associated with a statistical significance. And according to this, what you can see is that statistically, there was more fatigue here in the people with insufficient or moderate exercise compared to high levels of exercise. So I think it's something that I definitely think there's a thing there. How much you can turn it around and do more fatigue to make it, do more exercise to make it better, and what exercise you need to do. I think as much as anything else, it's activity. You don't need a personal trainer and a smartwatch and a home gym to be able to do things, but actually doing aerobic exercise really makes a big difference in terms of things, and certainly something I recommend to patients to be able to do it in terms of something to look at. How to make a choice of treatment. Rachel will talk more about this, but it's a partnership as far as I'm concerned. So range of things. I have some patients I talk to, and I can see them glazing over, and they just come and say, tell me what the right treatment is. I'm not interested, just tell me what it is. Others that will come along and go, I saw this last week in blood, did you? And it's like, it's not a competition, but sorry, apologies, but but I do think it's a conversation. But there are it's nuanced. I've already talked about the fact of it's a bit simply around symptoms. How much do those symptoms affect you, not how much those symptoms affect me. But there are other things that we can look at that guide treatment. The stage of disease. I'm hard pressed to give someone treatment who's got really early stage disease, even if it's screwing with their mind about not being treated, just because it can make them worse. How much symptom, that is important. I'll come back a bit to these genetic things. This is where they start to become a bit more important. The same things I talked about before that can inform time to progression. Your choices, what are your preferences? What's your expectation? What's most important to you? Because there is sometimes a conversation about going, do you want to have treatment? I sort of have a conversation and say, right, I hear what you're saying. Do you want to have treatment? Actually, they weren't that bad. Other times it's like, I'm fed up with this. I want to do something about it. What's most important to you? Is it most important that we have the maximum remission, which might mean you're going to get a bit more toxicity? Is it more important to minimise side effects? Is it important about having tablets versus infusions? How many trips to daycare? Do you want to be in a trial? This type of thing. And that's what the treatment's actually like. So coming back to then what the options are, I'll mention chemotherapy and then I'm going to discount it. So chemotherapy works by damaging DNA. Chemotherapy, in its conventional sense, it's not like chemotherapy is bleach. It doesn't sort of dissolve the cells. What chemotherapy does is it damages DNA, the genetic code. Your body doesn't like having damaged DNA. Damaged DNA is one of the things that leads to cancer, so your body wants to get rid of it. So add DNA damage means the cell then is programmed to die. But difficult to know, how do you treat the bits that you want to? And this is the problem with conventional chemo. It targets cells that are growing more quickly. So one of the reasons that chemo is more effective for treating cancer than your normal cells is the cancer cells grow more quickly, so therefore they are more susceptible to it, and also the cells are a bit screwy, so they don't repair themselves so well. But ultimately, chemotherapy will damage any cell that's growing, and that's the reason your hair falls out maybe, or you feel sick, because hair is continuously growing, the lining of your gut is continuously growing, whereas your bone or your brain or something isn't, and therefore it's less affected. Thankfully, we don't have to do that. And this is just a reminder to me, this is when I gave this talk, I don't know, 15 years ago. So this was back when we had a sort of, by necessity, not design, a sort of age-adjusted way of giving chemotherapy, because we had chemotherapy was fine, it was effective, but it was only really applicable for patients under the age of 70, which is about 25% of CLL. So great if you can get it, but not actually relevant. So this was a German classification. we will call it the go-go group, which was about 30 or 40% of CLL, where you could give them intensive treatment and it worked. The no-go at the other end of it of people who were very frail and elderly, where it's difficult to give any treatment, and the majority was this group in the middle, which is somebody who is definitely not frail and elderly and can't be treated, but they're 78. They're not going to do very well if you give them intensive chemotherapy, but they want to have some treatment, and we ended up with something that wasn't very effective. This was a sort of depressing view of treatment from about 2010. Thankfully, that's all in the past, because of this evolution of CLL treatment. Historically, CLL treatment changed about every 5 years. So chlorambucil from the 1950s. There were a few trials that did chlorambucil with steroids, and then chlorambucil versus fludarabine, which came in the 90s. That was another chemo. Fludarabine was better, so we used fludarabine. Then maybe we'll try adding in another drug, cyclophosphamide. That worked better still. Then antibodies came along, so you can use antibodies against cancer cells. We make antibodies a part of our immune system. They recognize foreign stuff. You can generate antibodies against cells for diagnosis. This was flow cytometry I showed you. You can generate antibodies in cells to kill them. So adds specificity because they're going after it. So 2000, 2010s, we were kind of in the immunochemotherapy, immunoantibodies, chemotherapy. And that was that standard of care, fludarabine, cyclophosphamide, rituximab, which was good if you were young enough and fit enough to have it. 2014 sort of represented the massive step change in CLL, and this was when ibrutinib was licensed. So this was the first targeted treatment. And then since then, an explosion of new stuff. This makes it quite difficult though. It's a great position to be in, but when we did these trials, you waited 5 years and something came along and said, right, that's a new treatment, we'll do that for another 5 years. This is all just like stuff on top of stuff on top of stuff. So someone said to me, what's the best treatment? I was like, well, I don't really know, because in a good way, because it's changing, because the trial that I thought was the right one to do hasn't quite finished, and then the new one has now come along, and that didn't compare it with that one, so how do we go? It's a great position to be in. This comes back to the keep your powder dry argument though, lots of new things that are coming along. And the general good thing about these is they're mostly applicable to all CLL patients without reference to age. So that whole slow go, no go thing, it's kind of gone away, because you can do this for anybody, which is great. So it means that we've leveled up, and actually most people with CLL can have effective treatment that's not terribly toxic, irrespective of age and fitness. Of course, there are extremes, but it's a much better place to be in than we were 10 years ago. So what are the choices? And this is something that you're going to get if you come to the point of treatment. So you've been diagnosed, you go to the clinic. It progresses, and maybe you start thinking, oh, you know what, I'm more tired and my white count's going up and this lymph node is annoying me and I'm just slowing down. I'd like to have some treatment. We'll have a conversation about it. Well, I think we can just get rid of immunochemotherapy. That's FCR. I can't remember the last person I gave that to, which is great. So we end up with targeted treatments. And just to go, so these are all molecules whereby can we do something to more specifically target the CLL cells and have less of that off-target effect affecting normal tissues. So the first of these, BTK inhibitors. BTK stands for Bruton's tyrosine kinase, named after Dr. Bruton. He was an immunologist in the US in the 50s, I think. So just in terms of how this works, this is just a couple of cartoons to try and walk you through about why these treatments before. So remember I talked to you, chemotherapy, it damages DNA, and therefore it damages cells that are growing, but it damages all of them. This is something, as an example of how it is you can do something that's a bit more specific. So this cartoon, this is a CLL cell. CLL cells are abnormal lymphocytes, and lymphocytes have on the surface of them, or B lymphocytes, what's called the B cell receptor. It's a modified antibody. Remember I showed you what antibodies look like? That's what's on the surface of CLL, of both normal lymphocytes and CLL cells. And that's how the lymphocytes talk to the world. Remember I was saying that they go through that phase, they're born, they go into lymph nodes and they meet the world. That is through the B cell receptor. And they need that, and then they come back out, and then when they see that thing that matches that, then they can do their thing and hopefully get rid of it. But CLL cells, as with lymphocytes, require continuous signaling through the B-cell receptor to stay alive. If you switch that off, the cell dies. So what happens if it meets something, an infection, it binds, and that then sets off a cascade of signaling, so loads and loads of things get activated, which cause the cell to switch on, do its thing, and kill something. So if you switched off something that was downstream of it, then hopefully you can then do the same thing. Either it's effectively you're removing that signaling pathway, so the cell then dies. And BTK sits downstream of the B-cell receptor, so inhibit BTK stops it working. BTK isn't just expressed in CLL cells, but it's much more specific than what you'd see with normal chemotherapy. A second way, so drugs that inhibit BTK, ibrutinib was the first, 2014, and since then there are second and third generation BTK inhibitors. Acalabrutinib, zanubrutinib, things you may have been talked about. There are others that come through. General message, we don't use a lot of ibrutinib because the second generation ones are as effective and have fewer side effects. So don't tend to use much ibrutinib, but all the principle of it is the same. The second way of treating, another one, this is the other mainstay, is inhibiting what's called apoptosis. Now this is where we get into drugs like venetoclax or sonrotoclax. They're the classes of drugs that do this. Cells, when lymphocytes have a lifespan, as do all cells, they are born, they do their thing, and then they die. If they're not, they're immortalized and they stay around forever. And that's one of the things that happens in CLL. That process of programmed cell death is called apoptosis. And if you don't have apoptosis, that means that the cell just continues and continues and continues. And it's one of the things that happens in CLL is that you don't have apoptosis. And one of the reasons for that is that you kind of inhibit things like there are huge numbers of proteins that mediate apoptosis. One of the most important ones is BCL2. So BCL2 mops up the proteins that would otherwise cause apoptosis. So if you have too much BCL2, then your cells don't die. And it's one of the things that means is why CLL cells hang around forever. So venetoclax what it does is it displaces, it binds to BCL2, pushes off that protein that would cause apoptosis and restores it. So therefore, it causes the cell to die because you've got a balance between signals that make a cell live, signals that seldom die. In CLL, it's overwhelmingly live, not die. Give venetoclax, and you go the other way, so therefore the cell dies. And again, BCL2 isn't only expressed in CLL cells, but it's quite specific. So therefore, you don't see this effect. It doesn't cause a whole bunch of other stuff to die. So venetoclax comes in, it then means that the signal that makes the cell die then activates this thing, caspases, and the details don't matter, but the cell then dies. So it's another way that you can specifically target, and both of these things work very effectively. And there are two examples of how you can try to, if you understand how the cell works, you can then try and target it, and you get more of this, less of this sort of off-target effect. What about the choices, though? Well, there's a number of things we've got to come back to. I said to you, you've got biology, genetics, patient choice, patient demographics, how old they are, how fit they are. Patient factors are very important. Coming back to the slow go, no go, go thing, we've got to, when I'm sitting in clinic with someone, I've got to take into account who I'm sitting in front of. Am I sitting down with somebody who's 54 and therefore in the absolute prime of life? Or 84, and with it and sharp, but not somebody who's going to do very well with treatment. And the demographics of CLL, it is a disease of older individuals, and we know as much as I'm talking to Hilary earlier of coming back and then being described as frail. I'm not frail, in terms of things, but frailty, just as a concept of something, is is a factor of life. We know that there is greater frailty and more people are older with CLL. So this is a study that looked at comorbidity, for example, as you get older. So this is just how many things have started to go wrong as you get older. And no surprises, this is not in CLL patients, this is just in cancer, that you see more comorbidity and more complex comorbidity in older people versus younger people. And because of the demographics of CLL, we see more comorbidity, which we've got to take into account. But it's not just about age or comorbidities. There are different things, and this is where it becomes quite a nuanced discussion. So this is correlates of outcome in cancer. So we know, what is it? This is nothing to do with CLL particularly, but it's like what makes a difference in terms of cancer outcomes if you give treatment. Age, unfortunately, is a factor. It's not the only factor, and clearly there are fit people who are 70 and very unfit people who are 50, but it does make a difference. Comorbidity is another thing, how many other illnesses they have. And then performance status, which is just how much do they do? You know, I can tell quite a lot by, you know, how many times did you have to stop as you walked in from the car park. So a performance status scale goes from 0, which is completely normal, to 5, which is dead. And then you've got things in between. All of these correlate with outcomes. The problem is they don't. This is looking, when I talk to you about statistical correlation, again, I'm going to talk about statistical nonsense, p-values. This is looking at saying, if you try and correlate one with the other, do they correlate very well? So age and age, 100% correlation, obviously. Age and performance status, a bit. You get a lower value, which suggests that there's a stronger correlation. But then you've got these comorbidity scores. This is just the Charlson score and the Sears score. You may get people that will talk to you about, particularly around Sears score. It's the cumulative index rating scale, which is a means of asking someone 1,000 questions about your heart, your lungs, your kidneys, your bowels, and the rest of it, and giving a score which gives an idea about how things work. Doesn't correlate very well. No surprise there. There is no fundamental reason whereby somebody who is older shall have poor organ function. So therefore, it's quite difficult. And you need, and you know, sometimes it's a difficult conversation about how you put all that together in terms of making decisions. But I think if you feel that somebody is just saying to you, no, you shouldn't have treatment because you're 75, well, okay, that's true with chemotherapy, not true if you're looking at modern, sort of a more modern treatment, but it still is a factor, you know, we've got to take this into account. So then thinking about the treatment itself, okay, I might have treatment, but what's it going to be like? How effective? When I look at treatment, there's 3 things to look at, well, a number of things to look at. Does it work? Because if it doesn't work, what's the point? How many side effects do you get from it? Because that's going to be a trade-off. How long is the treatment for? And then the 4th thing is it funded? Because the best will in the world, there's stuff that there's no point having a conversation with somebody about a treatment that we have no access to. But these are all things that I have a view on and I'm sure my patients have a view on as well. But one of the things that becomes then difficult is if you look at the treatments, coming back to things I've talked about, what's the difference between them? Well, if you take headline figures, people will say, you should definitely have this treatment, you shouldn't have that treatment. There's not a lot of difference. So, BTK inhibitors, acalabrutinib or zanubrutinib, if you look at the trial data, about 90% of people respond. If you look at this, which is called time to next treatment, how long it takes before you need more treatment, median is just a statistical term for average, the 50% figure, it's more than 6 years. Works pretty well. Not perfect, but pretty good, and almost everybody can have it. Okay, what about the next one? Venetoclax, which I've talked about. We give that usually in combination with obinutuzumab, which is an antibody treatment. Response rate, about 90%. Time to next treatment, more than 6 years. Okay. Venetoclax plus ibrutinib, another combination that's available and licensed in the UK. Response rate, yeah, okay. All right, so that's fine, which is good. Good thing is you can give any of those pretty much to anybody, with some exceptions, and they all work very well. So good thing, it's positive. It's not perfect, it's not curative, but it's not rubbish. This is not life expectancy, that's before you need to have some more treatment. And it's a 50% figure. 50% will be less, 50% will be more. So, and ultimately, no one's a percentage. outcomes, I always say to everybody, it's a binary thing. It works or it doesn't work, so you need to say, but you can approach the treatment with optimism. But thinking about the toxicities, because this is sort of like how it starts to then inform what treatments I might use. So if we look at BTK inhibitor therapy, Bruton's tyrosine kinase, ibrutinib, zanubrutinib, acalabrutinib, generally well tolerated, but there are some things to think of. So blood pressure being one, for example, and this is not, this is relevant to people, particularly as they get older, more likely to have high blood pressure, more likely to have heart disease. So this was from the Mayo Clinic, a very big, no it wasn't, Ohio State, it was from a very big US university, where they looked at observed versus predicted instance of high blood pressure, and there was a very big increase, so 44% of patients on ibrutinib got high blood pressure. They had a very conservative record. It's like, blood pressure above 130, which is pretty good going, but I mean, nonetheless, a lot more than those patients that didn't it. And again, you could see here that the instance over time, it wasn't one that just sort of came and went. The longer you were on the treatment for, the more people got high blood pressure. So cardiovascular toxicity is perhaps a concern. The other thing with BTK inhibitors was atrial fibrillation, which is an irregular heart rate. It can be uncomfortable, but it's, there's a stroke risk that goes with it. It's not to be underestimated. And again, this is in patients this was from the Mayo Clinic this time, looking at the instance of atrial fibrillation over time. And you can see it just goes up and up and up. The longer you treat, the more you get. So you end up with longer term follow-up that maybe 1 in 6, 15% of people end up with atrial fibrillation on ibrutinib. And this was, again, looking at the comparator. So this is, at any given age, how much atrial fibrillation in the white bars did you see compared to people of the same age who weren't on it? And there was a significantly more AF, atrial fibrillation, in CLL patients. So a consideration. And that is something that then also turns into, what about more serious things? In the FLARE trial, which you may have heard on, this was a study that was done in the UK that was looking at comparing chemotherapy with ibrutinib plus venetoclax. There was an instance of more severe problems, and here on, sudden cardiac death. It's small print, but it can happen, particularly in people who have got cardiovascular problems. So if you're on a BTK inhibitor, don't go away from this thinking, oh my God, I'm now going to die of a heart attack. But it is something that it does come into it. Every drug, if you look at paracetamol, will have liver failure and death at the bottom of it. But it is a consideration in terms of choice of treatment, because this is a treatment you take open-endedly, and the longer you're on it for, the more side effects you get. Just to look a bit at comparison, this is just what I've already said in terms of what is the relative toxicity between ibrutinib and second-generation drugs. So this is some trials. I'm sort of trying not to show you too much trial data, but hopefully this is quite easy to follow. This is just looking at how much toxicity was reported in the trials for patients with ibrutinib versus zanubrutinib. This was in relapsed CLL. Again, another study, this was acalabrutinib versus ibrutinib in relapsed CLL. And what you can see here generally is that for selected side effects, the second generation drugs probably safer. So, for example, here, the rate of atrial fibrillation, 5% with zanubrutinib, 13% with ibrutinib. Blood pressure, not a huge amount of difference. Bleeding and bruising, not a big difference. Acalabrutinib, less high blood pressure, maybe a bit more atrial fibrillation. You can't compare one with the other, but generally speaking, what we see is that none of them showed that there was more using the second generation drugs, but overall, they are better tolerated. Venetoclax and obinutuzumab, what about toxicities from those? Well, this is not comparative, but you don't get the cardiovascular toxicity. The advantage of this treatment is it's taken for 12 months rather than the BTK inhibitors, which are taken continuously. But you do get more, it's intravenous. About half the people get reactions to the first dose of obinutuzumab, and about 2/3 of people get neutropenia, low white blood count. That's normally manageable. It's usually in the first 3 months of treatment. You might need injections to treat it, and there are other side effects that go on with this, but they tend to get better with time. So there's a trade-off from going, have some acalabrutinib or zanubrutinib, easy, walk away, pack a tablet, start taking them, come back and see me in a month. But if you take them over a long period of time, more cardiovascular toxicity. Venetoclax and obinutuzumab, you've got to spend a day in day unit having treatment for 8 weeks. And you might have infusions, and you'll be hooked up to things. It's not stronger. I mean, I think the important thing is, one thing that sometimes comes is that venetoclax obinutuzumab is intensive treatment. The trial for using it was specifically designed for people who had got comorbidity. It's doable, but it does mean that there's a trade-off in terms of how it is. And then the genetic factors. How do they play into this? Well, one of the things that's important here is this concept of clonal evolution. CLL doesn't stay the same. Some things do, some things don't. But if you took, so this is schematically showing, you start off with your CLL, that's at the beginning, a bunch of cells. The white cells are the ones that are relatively easy to treat, and then you've got in and amongst them a small number of more difficult cells. Have your treatment, the bulk of it goes away, but it's all the cells that are easy to treat that go away, and what you're left with is the not so good cells. So what we then see is the pattern of genetic mutations changes, because when it comes back again, it's those cells that expand. So therefore, the genetics of the disease evolves over the time. Most people with stage A disease, and I talked about, have favourable disease. You see fewer instances of high-risk mutations. As you treat, you start selecting out more and more. The only thing that doesn't change is the IgHV sequence, the immunoglobulin sequence. That's fixed in time. Whatever that was at the beginning, it will be forever. But the other genetic mutations, the NGS, the FISH testing, they can change. So it's important, the message here is that whatever you've had done at the beginning, you probably need to do again as you go through treatments, because it might not be exactly the same. Why is it important? Well, remember I said that that chemotherapy works by damaging DNA. And what happens when you damage DNA with chemotherapy, you switch on this whole pathway of things that cause the cell to die. And one of the things that you need, 2 of the key genes that you need to make the cell die are P53, which is on chromosome 17. So that's a FISH test. You can either look at it by the NGS, you can look for whether it's mutated, and the FISH test tells you whether it's there or not there. 2 sides of the same coin. ATM is a gene on chromosome 11q. You can look for that by FISH or by NGS. But both of them are downstream to the DNA damage pathway. So if they're mutated or deleted, they're absent, that means that you can damage the cell with chemo, but it doesn't cause the cell to die, which is why those mutations are prognostically very significant for treatment. They are less significant for these newer treatments, because the newer treatments, BTK inhibitors, BCL2 inhibitors, don't work like chemotherapy works, so they are to some extent independent of this. But they are still important. But rather than going through, if you look at all of these genetic tests, they all have prognostic significance in terms of saying, what does it mean? Now, how do you then put that together in terms of knowing what does it mean in terms of likelihood of treatment working? Don't lose sight of the fact, for most people with CLL, I've shown you the data, 90% of people respond, remission durations normally measured in years, whatever you've got. But if you start to drill into it a bit in terms of saying, well, if you split that by those other factors, remember I showed you, you can do studies where you take a group of people who are untreated, look at factors that are important, and end up saying when they're going to need treatment. You can do the same thing in somebody who's at treatment to say how well the treatment works. So the CLL IPI is one such score. It's similar factors that I showed you before on the IPSE and the other scores. So P53 is important, the mutational status, blood tests and stage of disease. And so again, you can ascribe a score, and what you end up with is, for patients with low risk disease, which is about a quarter, 5-year survival, 95% nearly, 80% are alive at 5 years, pretty good. Very high risk disease, thankfully small proportion, but they do worse. And this is a group whereby we've still got unmet need in terms of treatment. But the important thing here is this doesn't take into account impact of treatment. The CLL IPO was developed from a patient cohort treated before 2010. So this is with chemotherapy. So its relevance in terms of patient treated today is questionable. You can sort of infer similar things, but I don't think you can use it accurately. And again, binary outcome. It either works or it doesn't work, but I don't think you should use this. And if anybody did, I would be questioning, saying, well, it gives you a guide, but you cannot use this and then say, I'm going to give you venetoclax or whatever, and say this is the chance of it working. There is a score that was done that looked with ibrutinib. So this is specifically looking at patients treated with ibrutinib, so a reflection of modern treatment, similar, the usual suspects in terms of things that are significant. You add them up, you get a score. And again, I think the thing that's different here, there is still a difference. For patients who've got high-risk disease, 3-year overall survival, because that's the data they had, I can't tell you what 5 and 10 year were, there is a difference, but you don't drop off as much as you did with the IPI, which was for people who were treated with chemotherapy. And then the other thing with this is that in this, is 75% of the people in this study had relapsed disease, which is harder to treat. So it's not really a fair comparison. And generally speaking, we see better outcomes for people with first-line treatment rather than subsequent lines of therapy. So how do you put it together and interpret the data? Well, I will try just to say, I said I wasn't going to talk to you, show you lots of data, and I'm not. But one of the things that I do find can be useful sometimes, just to illustrate it, is to show people, say, well, I want to know a bit more about what the trial data show me. And you might get Kaplan-Meier charts. And if you go to other talks, my colleagues love putting up survival curves and showing you, and they flash up, and what does it mean? I just wanted to just talk to you about what survival charts actually tell you. So if you wanted to say, in an individual, either works or it doesn't work, if you wanted to describe what does the survival of a population of people, I treated 100 patients with something, and I want to see what happens over time to that population. It gives you an idea about when might they relapse, when might they die, how well the treatment works. And so this can be plotted as what's called a Kaplan-Meier chart, which, imagine here, this is at the beginning of a trial, you've got 100% of the population, and they're all alive. And then you plot it against time. And every time somebody dies or relapses, you drop off a point, so you go down. And it gives you an idea then saying, well, when you get down here to 5 years, how many patients were still alive? So this is where you derive these statistics that come out from things. And so it can tell you what happens over time, but also the pattern of things. Do people relapse early? Do they relapse late? Do they plateau in terms of saying, well, if you get past a certain point, do I stay in remission forever? So in an ideal world, the brilliant treatment that is fabulous does that. It's a straight line. However long you follow someone up for, they're all alive and they're all in remission. Perfect. We've cured CLL. No more of these charts ever need to exist. A treatment that's totally hopeless does this. You follow it up for a short period of time. Oh, that's a catastrophe. We don't want to be doing that anymore. And what you tend to end up with is something that looks like it's in the middle, where over time you see a rate of progression. And in most of the time with CLL, the longer you follow up, because it's not a curative disease, it will just keep going down the longer you follow it up. But then what then allows you to do is you've got 2 treatments, you can then compare them and then start to say, statistically at least, is the treatment better or worse? So that's a comparison of terms. Censoring, this bit they've got here, is of course not everybody, if you're following up, will have reached the same point. You don't do it when everybody's finished. So that would be that you end up with just saying, at that point in time, that's where that patient was, or that individual in the trial was. So it does mean that the shape of these can change, because if you do this very, very early, you can end up with predictions, but then as more people go through it, you get a better level of confidence that the curve is telling you something. So that's what it shows. That's also Kaplan-Meier charts. And actually, the good thing is if you look for many CLL things, you end up with two curves that end up looking quite like that. Because the good thing is that CLL treatment for most people is very good. So you have to follow it up for years with huge numbers of patients before you start to see separation. Gone are the days of doing trials which drug companies liked, whereby you would compare new and effective versus old and crap, and therefore you'd see within 1 year the curves were miles apart, and therefore everyone can go, brilliant, that's the treatment work. It's a good position to be in that actually many of these things end up superimposing. But I think in terms of then saying, well, what's the important thing? And this is where it's a question to come back to what is best. It depends on which endpoint you're looking at. And there are lots of endpoints you can use. Do I want to know overall survival? That's kind of the gold standard. Does my treatment make people live longer? What is the time to next treatment? Well, that's kind of a sort of surrogate thing, because it's like, well, I might not live forever, but it's quite important to me to know how long it is before I need some treatment. But what often gets chosen is progression-free survival. It's called it's a surrogate endpoint, because if you do a trial that's overall survival, it takes years to follow it up. So consequently, it takes forever to get the output from the trial, which is frustrating to investigators. You can't nail down whether the treatment's any good, and it's prohibitively expensive because of the length of time you have to follow it up. So trials are often done with can you use a marker that occurs more quickly, that you get a readout at an earlier point. So rather than looking at the overall survival, you look at progression-free survival, which is the time to either disease to progress or to die. So using progression-free survival, you get the readout more quickly, and you do a smaller trial, and you need fewer patients, so it's cheaper. And this was something that was looked at in terms of pros and cons. But at the end of it, what you end up with something is, does it necessarily matter? Because this is a question I come back to, saying what's best. Somebody might say to you, this trial, I'm going to give you this treatment because it's best, it's statistically proven. And so if we look at things, let's just take, high-risk disease. We'll split them by IGHV sequence to say, we know that, for example, we know that that's associated with some treatment resistance, so how are we going to treat it? So if you look at trial data, I'm not going to show you Kaplan-Meier charts because I said I wouldn't. Acalabrutinib, at 4 years, if you give continuous treatment, about 80% of the patients are alive and well with 4 years of follow-up. That's not bad. And it actually suggests that's a good thing, because you've said one is bad and one's not so good. Sorry, one is bad and one's better, and you've narrowed the gap. Venetoclax and obinutuzumab, 4-year progression-free survival, you start to see quite a big difference. Those patients with the mutated, 80% at 4 years versus about 70% if they're unmutated. And if you give combination of venetoclax and ibrutinib, again, a similar difference. So the conclusion of that is, and you might get told in clinic, therefore we conclude if you have unmutated disease, the not so good one, that treatment is better. Well, if you look at overall survival, it's identical. So consequently, you need to just think about the fact of what's more important. Is it the time you're going to be in remission in terms of how long you're off treatment, or is it actually that for many people the sequencing might not matter very much? Now, in terms of how I use it, in terms of other data I'm not going to show, the one thing that has come back that comes through literature is, from a patient perspective, and I can't speak to you as patients, I can just tell you what the literature says, is that being in remission is quite a good thing. It's popular. It's associated with better quality of life. And if you buy into that and say, I know it might all end up the same thing, but I just want the treatment that's going to keep me in remission for the longest period of time, having acalabrutinib is the most efficient way to do that if you've got unmutated disease. If it's a case of saying, well, I like the idea of having a short duration of treatment, be done with it in a year, I know I'm going to need some more treatment probably a bit sooner, but I quite like the idea of not taking acalabrutinib with its risk of high blood pressure for the next 5 years, or 10 years, or however long it's going to be. So it's nuanced in terms of how you look at this. And I think this is the bit about the fact of just be a little bit wary in terms of things that can be presented as statistical certainties, which are statistically correct. Are they actually relevant to you as individuals? So it's complicated, and I think it's a case of I view it as a partnership. You know, there's all these things. My role in things is not just to go, there's the treatment you choose. I'm not doing my job very well if that's the case. I have a view on sometimes, but equally what I hope is something, the person sitting in front of me says, this is what's most important to me. I would like to have some treatment. How is it going to be? These are the things most important. I can say, we've got these choices. These are things that inform my decision, and then when you get there. And there's no right or wrong thing to it. But I don't think it's a sort of, this idea of like, well, it's definitely this or it's definitely that, probably isn't there. The one exception is probably people who've got p53 deletions. That's particularly important with chemo, as I've shown you, and it's the one thing that's still a problem with these newer treatments. And if you give time-limited treatment, 12 months of venetoclax obinutuzumab, 15 months of venetoclax and ibrutinib, then the time to progression is shorter, but it also seems to impact on overall survival. So that's the one group that I have a sort of strong feeling of saying, I think BTK inhibitors are my preferred option there because of overall survival. The rest of it, if you've got good prognosis disease, I don't think it makes a blind bit of difference, and it comes down often to a case of when I'm sitting down with somebody who doesn't have comorbidities, it's what do you prefer? You know, do you want short duration of treatment or do you want this? And you know, and there's no wrong choices there.
The first one: how do general survival rates take into account mortality from other cancers that patients have an increased risk of developing?
Well, I guess is that if you look at, there is an increased risk of other cancers that occurs in CLL, for example, and so it is likely that whatever happens in CLL development, that there will always be a difference between CLL outcomes and the general population, which is encapsulated with that. I suppose that what I would say is that a lot of it, the dominant factor in terms of mortality is driven by CLL survival. It's the most common cause of death in people with CLL. That's where there's been the biggest difference. But coming back to that chemotherapy is that the worry was then you could then replace one problem with another thing, and therefore you treat your CLL very effectively, but then you could end up with other complications. So it all adds into the mix. And no one's going to live forever, and I can't do it, but I guess that it does factor into it. But the point being is that what we're seeing is big changes in a positive direction, which is both in terms of toxicity, including second cancers, and the outcomes in the CLL itself.
Thank you. And one final further question, sorry, John. How do you approach neutropenia in a CLL patient who is on acalabrutinib?
It's all dependent on why it is. So as I said, it's more common in venetoclax. It's very common toxicity. You can see it on acalabrutinib, and it depends on the stage of the disease. So if you start off with a very high white count and your bone marrow is full of disease, then it takes a while for that to clear out. So your blood counts can get worse before it gets better. My general trying to do it is that if somebody's otherwise well, is to press on, because if you don't treat the disease, then it doesn't get better. But you may need you need to be vigilant for infections. You may need growth factors to stimulate the white cells, the neutrophils to recover. You may need antibiotics to reduce the risk of infections, but often you have to persevere. But if it's somebody who's very neutropenic and they haven't got lots of CLL and it seems to be disproportionate having lots of infections, then you then have to think about reducing the dose of the treatment. One thing I would say is that another thing about dosing in treatment is that it's to some extent a bit arbitrary. So when studies are done to define the dose of treatment, you escalate to the maximum tolerated dose. It's not the maximum efficacious dose. And then reach that point, great, and that's the dose. And then that carries on. There was a study that was done a few years ago which looked at saying, well, ibrutinib, the dose is 420 milligrams a day. So then somebody then looked retrospectively and said, well, what happens if you give 280 or 140? And actually the outcomes were exactly the same. so it doesn't seem to make a difference, at which point Janssen then made the cost of all the tablets exactly the same, so therefore it doesn't matter what dose you're on. But you can play around with the doses a bit sometimes, and I wouldn't be worried. It's not like if I'm not on the dose, then therefore my treatment's completely ineffective. I've treated a lot of people with dose modification, and they get very good outcomes with it, and that can sometimes be, if you see neutropenia, what you have to do just to find optimal spot between making it work but not giving too many infections.
I have a question about consultants. So I can see there's an awful lot to learn about CLL, and things are changing very rapidly, and it must be really hard trying to keep up with it all. But how important is it for you to have a consultant who is a CLL specialist rather than a general haematologist?
It's a good question. So 20 years ago when I first started in Manchester, there was a bit of work that was done by CLLSA, and their booklet at the time suggested that everybody who had CLL should be under an expert, and then had a list of who the experts were, which caused all sorts of ructions. I remember in particular Paddy Carrington, who's retired, who's a very, very eminent haematologist, president of the British Society of Haematology, looking at me, Adrian Bloor, month in post number 1, going, I'm an expert and you're not on the list. And it's a bit of, yeah, okay. But I think the important thing is that not everybody can be under a CLL specialist, and actually doesn't need to. Patients with early stage CLL actually are best measured through their GP. We should be demedicalising people. If you haven't got any symptoms, this can be done with once a year remote follow-up once you're sure about it. And there's excellent models for doing that in Leeds, for examples, so you don't need to be coming to a clinic. And in terms of things, dragging people back, it's lovely to see people, but just to say, yep, your white count's the same, off you go for another year. So I think you can manage that care in partnerships. The other thing though is if it gets to the point of treatments or a trial or it's not going right, this is where MDTs should pick this up. So every hospital is linked into a multidisciplinary team meeting. So that will mean that there should be and will be CLL experts who will be able to liaise with your team in terms of being able to guide them, and therefore hopefully levelling up, so therefore the advice you get is the same. If you're really not sure about it, and let's be honest, some people get greater, very good care, and others perhaps feel that they're not quite, you can ask for a second opinion. I mean, I think it is in the NHS constitution that you can have your treatment where you want it. If you want to travel 100 miles to go and have it treated in a tertiary centre, you can, and if you want another opinion, you can do. But equally, I think it would be it's something that many DGH haematologists who see lots of things are absolutely equipped to be able to deal with this and to be able to manage it. I sometimes see people, they come and see me, a bit of reassurance at the beginning and maybe a conversation about treatment. I don't ever think it's in their best interest to have somebody coming from West Wales or north reaches of Cumbria necessarily to be having a 4-hour round trip to see me every time. So it's another partnership thing.
One soundbite that we picked up recently was in the early stages not to make people into patients.
Yeah, don't medicalise it, absolutely.
What are the options for 3rd and 4th line treatments, and how's that affected by NICE and funding?
So, good thing is, as I said, in terms of treatment, we've got those 3 options. NICE, who dictate what we can give, talk about sequencing and when you can use things. But the good thing is that we have access to BTK inhibitors before and BCL2 inhibitors, and you can use one before the other and the other. So, you can use, in terms of sequence, you can actually have all of these things with the exception of venetoclax plus ibrutinib, but you can use them and it doesn't prescribe whether you give one before the other. So we have got more than one line of treatment available, and in general what we tend to do is that if somebody has had a BTK inhibitor and that hasn't worked, then you would then move on to a BCL2 inhibitor and the other, and vice versa. And coming back to the question that given the fact that they can last for many years, that sometimes is all the treatment you ever actually end up needing. So they're available and currently funded, which is good because it's not then dependent on things that may become available. The other conversation, coming back to the question you've raised there, is around what's new. And I think that in the context of 2nd and 3rd line treatment and subsequent lines, this is where there ought to be a conversation about a trial in terms of looking at it, in terms of, because it gets a bit more complicated, and sometimes that would be a good thing to be thinking about. Thinking about trials, do they preclude you, can you have a trial treatment means you can't have your NHS treatment? Sometimes you have to think carefully about the optimum sequencing of things, but it's worth just sort of weaving that into it. Trials in first-line treatment, it's quite difficult. There aren't really any trials around in first-line treatment at the moment because of the fact the treatment gets so good that it becomes quite difficult to do a trial to actually make it work because the comparator is too good. So I think that's where you go. The proportion of people, the harder the disease is in terms of if you're in the proportion that doesn't do so well and you've had multiple lines of treatment and short remissions, that's when it changes completely, and that's when I do think you probably ought to be seeing a CLL person to be saying, well, this is not the standard thing where I've had my acalabrutinib but I've been on it for 10 years and I'm absolutely fine. If you're in the group, well, I've had that for 2 years and that didn't work, and I've had my venetoclax and that didn't work, that's when you need to be then thinking about, well, what's new, what's different, how can we overcome this? That's when conversations start to come about intensive treatment and newer treatments and bone marrow transplantation and things. But the good thing is, I think, it's not really answering the question, is that we've got a number of standard treatments, and that means for the majority of people, for a lot of their treatment history, then we have access to readily available, generally effective, generally well-tolerated therapy. But at the margins, there are always things whereby you need to then think a bit more laterally about what you do.
Last question.
Okay, thank you. Can you hear me? Have I got this in the right position? I get what you're saying about, obviously, you're not giving individual individual medical advice. So this is completely hypothetical.
Obviously, okay.
For a person on a BTK inhibitor who was maybe had moderately high cholesterol levels and was hesitant to take statins, would you say don't be hesitant?
No, I mean, you need to think about drug interactions. That's another thing, that's sort of being on a whole bundle of stuff. But there are theoretical interactions between statins and BTK inhibitors or BCL2 inhibitors, but generally speaking, you can get away with it's fine. You might need to just monitor a bit more closely to start off with to see if it caused any toxicity or any side effects. But I would be, given that both of these are chronic conditions, it would be wrong not to treat the CLL. It would definitely be wrong not to give good treatment for the CLL, but also wrong to then say, well, then have a heart attack or something because you've forgotten your cholesterol's high. So you do need to. Where it becomes a big issue in terms of particularly BTK inhibitors, I worry, is uncontrolled high blood pressure. That's something that does seem to be an issue. But if it's well controlled and just taking a bit of ramipril, I'm not worried about it. But if you're on multiple treatments, that's when it can be an issue. Or people who've got a significant history of heart disease, somebody who's had a heart attack and things, I'm not so worried about, best will in the world, lots of people end up with some cardiovascular risk factors, but they're not all the same. But I think the statin thing is fine. It plays into it, but it's definitely not an absolute contraindication. Theoretically, obviously.
Okay. Thank you. Could I get a final round of applause, please, and a show of your appreciation?